sixth year medicine. And I'm so excited to be teaching this to you guys because it's my favorite anatomical system. I'm a little bit biased. Anyway, we're gonna go ahead and start. So this is renal anatomy. It's a question and answer session, basically going over some practice questions that can come in your exam in the same format. And I will be giving the first half, and then my colleague Bushra will be giving the second half. Okay. Again, anytime you have questions, please feel free to stop me or unmute yourselves and ask. Okay, so these are all the things that we're going to be covering today. I will be covering the first four things. So, your guys' posterior abdominal wall anatomy was done in two parts, and then you have your kidneys, and then the ureter's urinary bladder. So, I'm going to stop at the bladder, and then everything below that is going to be done by Bushra, and she's also going to go over the clinical and radiological anatomy and the cross-sectional anatomy. Okay, so the way I wanted to do this initially was like external to internal. And you're gonna see that usually Bushra will also explain it to you in like the cross-sectional anatomy. I'm pretty sure she's gonna go over that. But it's important for you guys to know basically from even internal to external, but I think it's easier for you guys to learn it from external to internal, everything in order. Especially because these are all, we're kind of focusing in on a system that is retroperitoneal. And I know that you guys have heard that word by now. So do you guys know what that means? Anyone in the chat? Okay, great. So somebody tell me what it means. It's pretty self-explanatory in the word itself, but somebody say it. Great, Sidra. So posterior to the peritoneum. It's literally in the word itself. So retroperitoneum, behind the peritoneum. And I know you guys didn't take GIT yet, which in all honesty to me is really odd. I know that they kind of switched around your guys' curriculum a little bit. In a lot of ways, it's great. And in some ways, I personally find it confusing because in GIT, that's when you learn about the peritoneum. But all you need to know is the peritoneum is a connective tissue holding a majority of your gastrointestinal system together, and your intestines in place. And the things that we're going to be talking about are mostly behind that, okay? Mostly. So here we can kind of see the external to internal or just like the part of the cross section. So you have, your skin, your connective tissue, your fat, you have your vertebra. So this is like one of your vertebral bones or discs. In front of that, you have your aorta, your inferior vena cava, IVC. You've got your muscle, so you got your quadratus lumborum. You have your psoas major, which you guys have seen. You have then your kidneys. You've got your ureters. You've got your perinephric fat, your renal fascia, Gerardo's fascia, and then in addition to that, in the retroperitoneum, behind the peritoneum, you've also got your ascending and descending colon, you've got your pancreas, you've got a few things. And remembering all the organs is important, not just for now, but literally in your next 2 years and even for your guys' like eventual board exams. Everything you learn obviously builds up. No stress. I promise, no stress. So a really good mnemonic to remember that, and I'm pretty sure some of you have already heard of this, is SAD pucker. So SADPUCKER. So S is for suprarenal or adrenal. A is for aorta or IVC. So just remember like your major vessels, aorta, IVC. D is for duodenum, the first segment of it, not the whole duodenum. The second, third segment are within the peritoneum. They're intraperitoneal. Then you have your pancreas, your ureter, colon, kidney, esophagus, and rectum. Okay, these are all retroperitoneal organs and structures. Okay, so let's go to our first question. A 45-year-old woman develops an abscess medial to the psoas major muscle. Which of the following nerves is most likely to be directly affected by this abscess? What do you guys think? You can say it in the chat, you can say it out loud. And it's okay to get it wrong, by the way. This is the time to get it wrong. Okay, so we've got 1D, genitofemoral. Any other options or guesses? Okay, change it to E. Anyone else? Okay, another E. I want one more person and then we'll go to the answer. Okay, so Sidra also says E. All right, so the answer is E. Good job. Okay, so it is E, obturator nerve. So this is just a matter of understanding where all the nerves are anatomically, which ones are lateral, which ones are medial. So over here, we can see in this picture, this is the obturator nerve. This is the most medial nerve. And we know that medial means closer to the center. Lateral is on the outside, right? So medial is going to be over here in the obturator, around the obturator nerve. So it's going to be compressing on the obturator nerve. So does anybody know what's going to happen because of that? What happens when you have compression of the obturator nerve or dysfunction of the obturator nerve? I don't know if you guys have you guys done MSK yet? No, I don't think so. I think that's next semester. But does anybody know? Because it could be, for example, something that, a patient presents with, and then that's how you find out that they have an issue and maybe they have a psoas abscess. Okay, so Noor said tingling in their leg. Okay, so the obturator nerve is usually like a motor nerve. I know I'm going into territory that you guys haven't really covered, but I just thought it would be like a fun fact. So don't worry if you don't know this. It's very, very new information. So it basically supplies the medial aspect of your leg. So all those muscles over there. And those are responsible for adducting your leg. So basically moving your legs in together. So you won't really be able to adduct your leg or cross your leg easily. That's one thing. And there's usually a triad for a psoas abscess. I don't know if they're going to bring this to you, but for example, if you have someone who they say like this person has a fever, they've got back pain, they have a limp, a limp because they're not able to walk properly, because not all their muscles in their legs are working properly, because, for example, there's nerve dysfunction because of compression or whatever it is, you know that that could be a psoas abscess. An abscess is a collection of pus because of an infection. Okay. So it's like taking up space. And psoas because it's in the psoas major muscle. Okay. So good job, guys. E, obturator nerve. That's the most medial one. After that, you've got the femoral nerve, then the lateral femoral, cutaneous nerve. Then you've got your ilioinguinal, iliohypogastric, which are coming from T12L1. Okay. These ones are usually, if you guys know where your kidneys are, these are basically posterior to your kidneys. Okay. So good job. You guys pretty much got it. All right, this is an example of a perinephric abscess. So, for example, you can have an abscess even behind your kidney. And then, for example, if somebody says, okay, you have a perinephric abscess, they saw this on a CT, they see this in cross section. Bushra, for example, will show you the radiology. So, this is, for example, a radiological image. And they say, which nerves could possibly be damaged? You're thinking, okay, this is behind the kidney, so which nerves could possibly be damaged? What would you guys say then instead? You just saw the image I showed you. What would you guys say? Which nerves? Give me two. Okay, Mokshit said iliohypogastric. Excellent. That is the main answer. So good job. That is the main answer. Iliohypogastric is good. You can even say, what was the other one? Ilioinguinal. Exactly. Good job, Noor. Ilioinguinal. But iliohypogastric is usually the one that's more commonly mentioned and I think affected. Okay. So, well, I think I just asked you guys this question. I forgot that I had put it in. But during a renal biopsy procedure, a nerve which lies posterior to the kidney is traumatized. Which of the following nerves is most likely affected? So all of you answer because now you know the answer. A, ilioinguinal. Good. Sorry, I said iliohypogastric. I meant to say ilioinguinal. Okay, great. Perfect. So I don't think I need to go more in depth about this. I think you guys pretty much understand. So anything, for example, they're placing a needle in a biopsy, there's an abscess, or there's, for example, kidney cancer, there's a huge mass growing. Obviously, you have structures around, you've got your muscles, your nerves, you've got arteries, veins. These masses or these infectious, pus like growths or whatever, they can all compress on the structures nearby. So oftentimes you'll usually notice symptoms via nerve dysfunction or like nerve compression. So ilioinguinal nerve, where are you going to lose sensation? Back. You're also going to lose it in the inguinal region, right? Which is like basically in between your suprapubic area, your thigh, and inner thigh. Okay. Am I thinking of genitofemoral? I might be also thinking of genitofemoral. But either way, genitofemoral also traverses in the same direction. So these can all be affected. Okay, good job. All right, so over here you can see these are your kidneys. Okay, tell me guys the poles of the kidney. So the vertebral levels, the top and the bottom. Where do they span from? Which vertebra to which vertebra? Great, T12 to L3. Perfect. Okay. And which kidney is lower? Right. Why? Why is the right one lower? Perfect. Because of the liver. Literally because of the size and the margins of the liver and because it's a tough tissue. The kidney cannot go up into the liver. Perfect. All right. So remember we have our obturator that is medial. Then over here you can see where is it? There. Traversing behind the kidney, you've got your iliohypogastric, ilioinguinal. These are the ones that are traversing behind your kidney, and they're most likely going to also be affected, okay? If there's any growth or if there's any perinephric abscess. Perfect. Okay. So, next question. Blood from an injured kidney will seep through the perirenal fat until it contacts the internal surface of the renal or Gerota's fascia. Without perforating this fascia, the blood could then continue to pass in what direction? What do you guys think? Is it A, inferiorly towards the pelvis, laterally into the body wall, C, medially across the midline, or D, superiorly into contact with the fascia of the diaphragm? Okay, so majority of you said A, which is correct. It is A. So remember, if it's not going outside of Gerota's fascia, it's going to be following where the genitourinary system is going, which is downwards into the pelvis, right? Because it's going to follow from the kidneys into the ureters and into the bladder, right? Now the urinary bladder. So the ureters are retroperitoneal and the urinary bladder is below the peritoneum. It reflects off. And in women, it's also going to reflect off, for example, the uterus, okay? And then this is the bladder, this is the uterus. So the peritoneum is going to go like that, okay? Perfect. So you guys understand that? I'm going to take that as a yes, and we're going to move on to the next question. All right. So this is just an example. This is your renal capsule. This is the Gerota's fascia. So it's going to follow down into the ureter. So your Gerota's fascia is covering all of that, okay? But the renal capsule is only covering here. So for example, if you have subcapsular hematoma, sub meaning below or under, capsular, so below the capsule, it's not going to spread everywhere. It's not going to spread downwards into the pelvis. It's going to stay around the kidney. It's going to cause severe kidney dysfunction because of the compression. Okay, but if it's in between the capsule and the renal capsule, that's a perinephric hematoma. So peri is like upon, nephric, the nephrons are like the kidney itself. So it's going to be above that, but it's going to still be within the Gerota's fascia, the renal fascia. So it's going to spread down into the genitourinary system. So I think you guys understand that pretty well. All right, next question. By the way, I mixed these kind of all together because in your actual exam, obviously they're not going to say like, this question is going to be from this lecture about the retroperitoneum or posterior abdomen or the bladder or the prostate or whatever. So they're kind of mixed here and there, okay? So I kept that like that on purpose. Okay. Which of the following does not form part of the boundary defining the trigone of the bladder? A, intrauterine crest, B, left ureteric orifice, C, right ureteric orifice, D, urachus, or E, urethral orifice. Okay, so Noor said D, Maya said D. What else? Who else wants to answer? Okay, Mokshit said D. Okay, great. So you guys are correct. It is D. So let's look at a picture of this. This is straight from your guys' slides from Dr. Elena. But basically, you have your ureteral orifices here, your left and right. Well, this one is your right, this one is your left, because we're looking at it as if we're looking at the body anteriorly. Then this is the urethral orifice, okay? This is the landmark if you guys have seen in your lecture about a cystoscopy. So cystoscopy is where we take a little camera through a little like catheter. We put it into the urethra from externally, and then we go into the urethra, into the bladder. So once we see this, we see a lot of vascular markings. Then we see this area over here. That's how we know, okay, now we're in the bladder, we're at the trigone. And then that's how we know to turn it, the camera left or right to look for the ureteral orifices, okay? So this is the trigone of the bladder. So the urachus is not even related to any of this. So when you're looking at this, for example, the trigone of the bladder is actually going to be on the posterior wall of the bladder because that's where the ureters are entering from, right? In the vesico-ureteral junction, basically where they're meeting, that's posterior to the bladder. It's not going anteriorly or laterally. It's going posterolaterally, basically. Travels in like this, okay, in the back of the bladder. So the urachus is actually placed like anterior superiorly. And this is basically because, when you're in utero, when you're a fetus inside, the mother's womb, this is part of the umbilical cord, right? Because remember, like fluid is circulating in between your amniotic fluid and etc. You're swallowing that, you're also producing urine, and then this is all, everything is connected. So this is called a urachus. If this stays open, it's called a patent urachus. Otherwise, this becomes the umbilical ligament, okay, that's attached to your bladder. This normally goes away. So this has nothing to do with the trigone of the bladder, but over here you can see. So the urachus, let's just say if this was like all closed, the urachus would be over here going up anteriorly, right? The trigone is actually in the posterior wall of the bladder. Does that make sense to you guys? Do you need me to clarify anything from that? Great. Okay. Any questions up until now? I feel like I may be going a little fast, but you guys are also pretty good. Great. Okay. So, next thing. All right. A 50-year-old female presents to the emergency room with complaints of left side abdominal pain and fever for the past 2 days. CT scan of the abdomen confirms a large perinephric abscess. The fluid was most likely accumulated between which of the following coverings of the kidney? A, renal fascia and transversalis fascia. B, perinephric fat and endopelvic fascia. C, renal capsule and renal fascia. D, transversalis fascia and parietal peritoneum. Or E, renal cortex and renal capsule. What do you guys think? Okay, so you've got one C, two C's, three C's, four C's. Anything other than C? All right, no, nothing other than C. Um, so we've already kind of discussed this, but you guys are, sorry, correct. Renal capsule and then renal fascia or Gerota's fascia. Renal and Gerota's fascia are the exact same thing. So a perinephric abscess is a collection of pus due to infection in between the capsule and Gerota's fascia. That's perinephric. If I said subcapsular, what would the answer be? There was a subcapsular abscess or there was a subcapsular collection of fluid. Great, good job, Mokshit. So it would be E, renal cortex and renal capsule, because it's under the capsule, but it's not in the kidney. It's outside the cortex of the kidney. Perfect. Okay. So we can go over that very quickly again. So this is your kidney. This is the renal capsule, the dark purplish pink line, magenta line. If we said subcapsular, it would be cortex and the capsule, right? That would be here. But we're talking about a perinephric abscess. So it's upon nephric, perinephric, which means like upon the kidney. So it's here, but perinephric is not outside the renal fascia. Otherwise, that would not classify as a perinephric or renal, abscess. So the abscess is located in between the capsule and renal or Gerota's fascia. And there's multiple causes. There's UTIs, other infections. There could be trauma, for example, if someone gets a stab, obviously you're introducing bacteria from the outside to the inside. So that can all cause abscess formation or infection, okay? That you will learn more about in third year. Fun fact. Okay, so next one. A 49-year-old man came to the clinic with the renal colic episode. His ultrasound examination confirms the renal calculus lodged in the first constriction of the ureter. What is the vertebral level of this first constriction? Tell me, T8, T11, L4, L2, L1. All right, so we've got two E's, three E's, four E's, five E's. Okay, so let's look at the answer and discuss. So the answer is actually L2. And I know why you guys are saying E. Now, if your lecturer is saying E, L1, then in your exam, go by E. However, because I did see this question from before, it's a commonly asked question. The answer everywhere else is L2. And I'm going to show you guys now and then even again later in this lecture because there are other questions related to this. But it also depends, it doesn't necessarily depend fully on the kidney left to right because the other kidney is not that much lower. I know what you mean, but it's not that much lower. It's only like a couple centimeters. And your vertebral body is more than just a couple centimeters. But I know why you're saying that. I actually thought the same thing at first. I was like, okay, well, maybe the question was specifying right. But then I reread the question and it's not specifying right. So I will show you guys right now because I wanted to believe L1. I'm like, that makes sense. But if you look at the poles of the kidneys, like you guys told me, T11, T12 downwards until L2, L3, usually L3. So L2 is more for the left kidney, L3 for the right kidney. Over here in the next one, so we already answered this question. I asked this to you guys earlier, why the right kidney is slightly lower than the left due to the size and margins of the liver because of the presence of the liver. But in this one over here, if you see T12 to L3, that's usually the poles of the kidneys. The first constriction is not immediately right outside of the actual kidney. And also your ureters are going downwards. So it's actually around L2, even at the upper pole of L2. So it's still at L2. And there's other radiographic images where it's going to show you that it's more in line with L2. Now, again, I'm going to really reiterate and stress this. If your lecture, if Dr. Elena is saying put L1 in your final exam, okay? Go by what your lecturer is telling you. That's the most important thing in order to get it right in your exam. However, because I was also confused, I found L2 everywhere else. I think that is a question to maybe bring up to her if you guys do have time to, okay? All right. So we can see the poles of the kidneys over here. We can see the uretero-pelvic junction is located at approximately L2. And now this is one really, really important thing that you guys need to know. I honestly think if you guys are not going to remember anything from renal anatomy in general, if you want to remember one thing, I think this is what you should remember because I've noticed this coming up again and again and again, literally not only in renal, but in a lot of stuff, okay? First constriction is at the pelvic junction. I know it says level of L1. If they're telling you to go by L1, go by L1. But everywhere else, I'm finding L2. Okay. So if you want to like in your head replace this with L1, go ahead. Okay. So you know what? For the sake of this, if you guys are adamant L1, we can keep it L1. But everywhere else, it's saying L2. That's the only reason I wanted to really include it in there. Okay. In fact, I might go ask myself because I'm actually really curious now as to what exactly it is. Okay, so the pelvic junction is an L1 or L2, depending on what you want to go with. Okay, that's your first one. Then there's there's three constrictions. So number one, we just talked about pelvic junction. Then you have the second one, which is where your ureter crosses the pelvic brim at the sacroiliac joint. Okay, so your sacrum and your iliac crest basically meet and they make your sacroiliac joint. That is the level. And another way to remember that is, for example, this is where your common iliac arteries bifurcate into the internal and external iliac arteries, okay? That is where the other constriction is, okay? That's what's causing the constriction at that site because it's going through that bifurcation, okay? Now, the last thing is the third one, which is the vesico-ureteral junction. So vesico, like vesicle, ureteric junction. Vesicle, you can think about, your bladder. Ureteric junction, so where they're meeting, basically. That's another side of constriction. So the two most common ones are actually ureteropelvic or pelvic-ureteric junction, and then the vesico-ureteric junction. Okay, these are the two. And the third one, it also happens here, but these two are the common, basically the most proximal and then the most distal. Okay, this is at the level of the ischial spine. So let's look at these separately. So ignore the catheter, ignore all of this. I included this image for you guys to see the level at which, for example, there's the aortic bifurcation into the common iliac arteries, and then further bifurcation into your internal and external iliac arteries, which is where the second constriction of the ureter is. Okay, so that is at the level over here of the sacroiliac joint, which you can see over here. This is your sacrum. These are your iliacs. This is the sacroiliac joint. Okay. This is where the bifurcation is happening. This is where the second constriction is. Okay. And remember, this is also a really common question a lot of the time. Where is the bifurcation of the abdominal aorta into the common iliacs? L4, 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 L4. You guys are not going to forget that now. Okay. L4. Now, the last thing, it's supposed to be moving. This is a GIF. Okay, anyway, it was supposed to be turning around, but you guys can see this pretty clearly over here. This is your ischial spine. It's below, even it's like at the bottom of your sacrum coccyx, that area, your sacrum. This is where the level of the vesicoureteral junction is, and that is the third constriction. Okay. Do you guys understand all of this up until now? Do you want me to go over anything again? Okay, I'm gonna take that as you guys are okay with it, and we're gonna move on. Okay. All right, next question. During a surgical procedure to reach the hilum of the left kidney, which of the following structures must be elevated and reflected? A, liver, B, stomach, C, ascending colon, D, duodenum, E, pancreas. Okay, we got one D. Okay, one E. I wish I knew your name, but 241052 is saying E. Okay. Another E, another E. Anything else? All right, so three of you have gone with E, one with D, perhaps. Oh, wait, no. So the answer is E. Good job, guys. Okay. Now, Sidra, I understand why you said D at first. Don't worry. Don't worry about it. I understand why you said D at first, but it is the pancreas. So let's look at the structures, basically. This was not blurry when I put it in. I am so sorry for how this looks right now. It's hideous, but it's very blurry, but hopefully you guys can understand this. So this is your left kidney and this is your right kidney. Imagine again that you're looking at a person anteriorly, right? So your right and your right will correspond with their left and your left will correspond with their right. Okay. So this is the right kidney. This is the left kidney. So the left kidney hilum is over here, which is where the body of the pancreas is. Okay. So you're going to have to reflect the pancreas to get there. Now, as you said, the duodenum is going over the right hilum. Okay. So you are correct in that sense. If we said the right hilum, the answer would have been duodenum. But because it is left, it is pancreas. Okay. I think that's pretty straightforward. I mean, honestly, you can't say stomach. I thought the same thing, but I think what they're referring to is your retroperitoneal organs. So, your pancreas, your first segment of duodenum, these are retroperitoneal organs. So once, usually in a surgery, usually in urology, you do a lot of retroperitoneal approaches because we remove some tumors, from the kidney. We remove tumors that from the testicles that have metastasized to the retroperitoneal area. We do a retroperitoneal approach, and what happens is we make an incision medially down the abdomen, and then we open that up, and then we basically go laterally. We just remove all of the intestines, peritoneum, put it aside, and then we look at what we have, and then we start reflecting on whatever. So we basically have moved everything, intestine, stomach, anything intraperitoneal, out of the way. It's literally out of the way. So what I think they're doing over here is just speaking about the retroperitoneal organs and structures themselves. I thought the same thing. So that's how I made sense of it. Okay. All right. Next question. Any questions about that? Any confusion? Anything you want to go over? Okay, I'm going to take that as a no, and we're going to move on. Okay. All right. So since we're talking about the hilum, what are the contents of the renal hilum anterior to posterior? Yalla. Okay, so renal vein, renal artery, renal pelvis. Okay. VAP. Okay, you guys learned it as VAP. Okay. Back in my time, we learned it as something a little bit different. So, but you guys are correct. So I want you to think of a van. So instead of VAP, I learned van. Okay. Oh, okay. All right. So it's van or VAP, as Mokshit wants to say, but same idea. Okay. So anterior to posterior, it's like van the ureter. So van U, if you want to say that, or renal pelvis. So it's the vein, artery, nerve, then the ureter. Okay, that's anterior to posterior. So when you're looking at someone, you're basically moving the vein. Then you're going to see the artery. Then you're going to see the nerve. Then you're going to see the pelvis, the ureter. Okay. All right. Van is applicable to multiple systems, by the way. You're also going to learn it in MSK. You will. Just a heads up when it comes to learning about the inguinal region. Okay. Van, just remember Van. It's gonna come again and again and again. All right. All right, next question. A 60-year-old male presented in the emergency room with complaints of severe right-sided low back pain. Examination revealed loss of sensation on the posterolateral gluteal and suprapubic regions. CT scan reveals a mass in the right kidney. Which of the following nerves was most likely compressed by this tumor? A, iliohypogastric. I'm sorry for the typos in the thing in spelling. B, lateral cutaneous nerve of the thigh. C, femoral. D, subcostal. E, obturator. What do you guys think? Okay, so we got one A, two A's. Anything else? Come on, guys. I want to have one more answer before I show you guys the answer. All right, another A. Are you saying A because they said A, or are you saying A because you think it's A? Anyway, it's okay. B is kind of tempting. Okay, well, let's talk about it. Answer is A. So good job, guys. It is the iliohypogastric. So the clue over here is suprapubic region. You will not get that in the lateral cutaneous nerve of the thigh. Remember, lateral cutaneous nerve of the thigh, B, is going to be literally the lateral thigh, like upper thigh area. Okay. However, over here, because you have the suprapubic region, which is basically literally above your pubis or your pubic bone of the pelvis, and you have your posterolateral gluteal region that is all supplied by your iliohypogastric nerve. Okay. A lateral cutaneous is more concentrated to just the lateral aspect of your thigh. Femoral, we know it travels down. Subcostal is literally below your ribs, it's more specific. And obturator is medial thigh. Okay. Do you guys understand that? Great. All right, so again, this is from your lecture. So the iliohypogastric nerve coming from L1, it supplies the skin and the lower part of the anterior abdominal wall and muscles of the anterolateral abdominal wall. Okay, so anterolateral, I mean, I realize I'm pointing at myself and it's not even showing on the camera, but suprapubic is basically above your pubic bone, so lower abdomen, and then anterolateral, so like on the side of your abdomen. Okay, great. Okay. All right. So this question, I put this question in myself. This is actually a case that I got to observe in the operating room in October when I was doing my urology rotation. So again, everything that you learn again adds up and you never stop seeing it. If that is, if you guys are ever doing something and you feel stressed and you're like, oh, when am I going to use this anyway? You're going to end up using it. So a 23-year-old male suffers from testicular cancer that has metastasized to the rest of his body. Imaging shows the presence of metastatic masses in his posterior abdomen. Through which lymphatic vessels did the mass reach from his testicles to his posterior abdomen? A, superficial inguinal lymph nodes, B, lumbar, C, mesenteric, D, celiac, or E, cystic lymph nodes. What do you guys think? Okay, so we've got C, we've got B again, another B. I want one more person. I like that we have different answers. All right, another B. Okay, so the answer is B, lumbar lymph nodes. Lumbar lymph nodes are also known as your para-aortic or aortic lymph nodes. And the reason that I ask this is because you briefly learn it here in renal, and you're going to touch upon it again at the end of the year when you guys do your endo-repro block, especially the repro section, because you're learning about testicular blood supply, venous drainage, and also lymphatic drainage. And remember, lymphatics always follow arteries, okay? Like it's like a rule of thumb. If you're not sure, remember lymphatics follow arteries, okay? So over here, the testicles drain into where they get their blood supply from, which is from the aorta, right? That you have your testicular or your gonadal artery. So they're going to follow there. So any structure in your pelvis, or most of the structures in your pelvis, are going to drain para-aortically through the common iliacs and para-aortically. Okay. Or over here, in this case, because it's specifically going, to the aorta, it's again para-aortic, which another way of saying that is lumbar lymph nodes. So this is again directly from your guys' presentation. Your lumbar lymph nodes collect lymph from organs of the posterior abdominal wall, organs and walls of the pelvis and lower limbs. Okay, so everything basically from down there going up here para-aortically or lumbar, because remember it's your lumbar vertebra, your aorta is right in front of it. So lumbar lymph nodes, para-aortic lymph nodes are within the same family of lymph nodes. They're considered the same thing. Is that clear to you guys? Do you want me to go over anything? I know someone said mesenteric. Do you understand why it's not mesenteric, or do you want me to go over that? I'm gonna wait for one of you to tell me you're not confused, and then we'll move on. Otherwise, I am more than happy to explain anything. All right, I'm gonna take this as you guys are clear on the concept, and we're gonna move on, okay? But I hope that is clear to you. That's a rule of thumb, by the way, for any system, any anatomy you learn. Lymphatic drainage follows the arteries, okay? When you're in doubt and you don't remember, just think about what is the arterial supply. That is the lymphatic drainage, most likely. Just say the same name. For example, iliohypogastric. Just say iliohypogastric again, okay? Or inferior mesenteric, mesenteric lymph nodes. That's a great example that we just went over. All right, okay. Internal iliac, external iliac, those are arteries. Those are also lymphatic drainage systems or ways. So those are also where your lymph nodes are located. Remember, they're located around your arteries, okay? Now, next thing. Okay, next question. The apex of the urinary bladder is continuous with the median umbilical ligament, MUL. Which of the following diseases may lead to a swelling in the area of the MUL in a newly born baby? A, exstrophy of the bladder, B, omphalocele, C, inguinal hernia, D, remnant of the mesonephric duct, or E, urachal cyst. Okay, Maya says E, Noor says E. What else? Sadra says E. Okay. Anything else? We got an I don't know. That's perfectly fine. Okay. All right. So we've got three people answering. So let's go ahead and see the answer. So it is urachal cyst, E. Good job. So it's a swelling. So in that case, you're going to think something a little bit more benign, which is like a urachal cyst, okay? Benign meaning like it's not horrible, horrible. It's like another way of saying not horrible, horrible. It's just benign. So over here, if we look at this, we can see different, for example, we talked about a patent urachus. Remember, this is where your umbilical cord is located, right? It's connected over here. So this is a patent urachus. This is if it doesn't basically disintegrate and become the umbilical ligament, okay? Now, you can have an umbilical polyp, which is basically where this part has all, I forgot, it's not the word, maybe disintegrated is not the right word, but we're gonna go with disintegrated for now. This is an umbilical polyp where it's open over here. Urachal cyst is where it's actually closed at the umbilicus at our belly button. and it's closed over here at the bladder, but there's a cyst. There's a collection of fluid still. Okay, this is known as a cyst. So this is what's going to produce the swelling. Now, bladder exstrophy, if you guys are not aware, is where your bladder is outside your body, exstrophy. Okay. Inguinal hernia is completely different. So it's basically where your internal organs and your abdominal organs are going to start moving through. There's internal and external, sorry, indirect and direct hernias. I'm sorry, not internal, external. My mistake. There's indirect and direct hernias. It depends on, the movement of where it's going, but it can go into the testicle, or into like the genitalia, usually the testicles, and then in a male child, or it can go into the inguinal canal, okay? So that's different. That will not produce the same type of swelling. It will not produce a swelling in the area of where the median umbilical ligament is supposed to be. So if you're confused about that, just think about the location and swelling, what's going to be there. Exstrophy of the bladder would have been described completely different. That's why it's not that. Phalloceal, same thing. Okay, that has to do with your other abdominal organs. So it's not in the same necessary location of your MUL, and it's not in relation to your MUL. Okay, do you guys understand that? I hope that's clear. All right, perfect. All right, okay, next. Okay, and I think this is my last question. Then you guys are gonna go ahead and become Bushra students for the next hour, hopefully. So, what are structures X and Y, and what is their clinical significance? We briefly went over this, so hopefully you guys remember. Come on, guys. Okay, let's start with X. First, tell me what X is. We talked about it.
X is the the first contraction, whatever that's called.
Uh-huh. First constriction.
Um,
Do you remember the name?
Constriction, yeah. Constriction is so it's called the pelviuretrical joint.
Yep, pelvic junction. Not joint,
Junction, yeah,
junction.
junction.
Yeah, perfect. Okay, good. Or ureteropelvic junction. Good job. And it is at the level of
L1 or L2.
L1 also. Yeah, I think you guys should definitely ask Dr. Elena about that. Everywhere I have seen or read, because I wanted to make sure it has said L2, but I know in your guys' lecture and previous exams, it has said L1. Okay. Now what about Y? What is Y?
Y is the third constriction.
Good. Okay. Where would the second one be?
The second one would be near the sacroiliac joint. It's just
Okay.
above Y a bit.
Okay, good. Good job. Good job, Moksh, and good job, Sidra. I can see it in the and Munib can see it in the chat as well. So yes, you guys are all correct. Y is the third where the ureter meets the bladder. So it's the vesico-ureteral junction. Okay, that is the third constriction. And yes, you're correct. The second constriction would be at the level of the sacroiliac joint, or what was the other way of saying it? The pelvic inlet, basically, I think. Let me go over that. We can go over it together really quickly. I forget things too, guys. Pelvic brim. Sorry, pelvic brim. That's the word I wanted to see. Okay, good. Okay, so what is the clinical significance of that, of X and Y? Uretero-pelvic and vesico-ureteral junctions. Pelvic brim. Thank you, guys. So what's the clinical significance? Last thing, and you guys are free from me. Good. Okay, good job, Sidra. So kidney stones mostly get stuck there. Good. Okay. So you guys were absolutely correct. X is the ureteropelvic junction at the level of L1 or L2, depends on what you're reading. Y is the vesico-ureteral junction, which is at the level of the ischial spine. Okay. And the significance is these strictures are, let me just There you go. Okay. These strictures are where stones often lodge, okay? Or where your renal calculi, which is another way of saying kidney stones, will often lodge, okay? So that is all I have for you guys today. That's from your first four lectures of anatomy that we're going to cover. Do you guys have any questions for me before I go and you guys go on to continue with Bushra?
I know it was very well explained. Thank you.
Oh, thank you. I appreciate that. Thank you so much. Anyway, if you guys don't have questions, I forgot to put my contact information. I'm gonna type it into the chat. I'm so sorry. I will also send it when I send you guys this PowerPoint or this presentation, I will include it in here before I send it to you. But I'm just gonna quickly type my stuff into the chat. You guys can take a picture, save this. WhatsApp. Okay. Yeah, feel free to contact me literally anytime, okay? This is like my favorite thing. I love renal anatomy. I love urology. So, Jenny, if you have any questions, feel free to ask me. And this is, if I'm not wrong, this should be the correct link, the QR code for the feedback, okay? So feel free to say anything. If there's anything that I can improve on, please let me know. If you want to say nice things, also feel free to say nice things. But if you want to say anything in feedback, I am happy and welcome to receive any of it, okay? Thank you guys so much. So Bushra, I think you're gonna take it from here. I think she's in here, right? Yeah, great. Okay. All right, so I'll just stop my sharing.
Thank you. Would you guys like to take a break before we start? Like a 5-10 minute break? Okay, perfect. My presentation is not, I'm gonna take the full hour. I think I'm gonna be closer to 40 minutes maybe. So okay, let's take like a 5-minute break and we can reconvene after.
All right. Bye, guys. Thank you, Bushra.
Thank
Thank
you. Okay, perfect. Let's start. Okay, assalamu alaikum everyone. I'm Bushra Rashid. I'm a fifth-year medical student, and I will be continuing where Iman left off for the renal anatomy practice questions session. Here's my contact information, my email address, and my phone number in case you would like to reach out at any time. Now, this is not just regarding this session. I would also encourage you to reach out if you would like any advice. Again, I am a senior medical student. If you want any advice regarding, anything in your med school career, or if you would like to give me constructive feedback regarding this session, anything at all, constructive criticism, I would appreciate it. And yeah, thank you. So these are the lectures. These are the lectures that I'll try my best to cover. I will be touching upon the most high yield points from every lecture. Of course, I'm not going to be able to cover everything, but I will try my best to go over the highest yield stuff. All right, let's start. So a 47-year-old woman comes to the office or the clinic with fever, dysuria, and abdominal pain. The patient has had several UTIs since her teens, but has no other medical concerns. The physical exam shows mild suprapubic discomfort. Urinalysis shows polyuria and many bacteria. The CT of her abdomen is shown in the image below. Okay, so let's break down the question first. Before even doing that, I've highlighted the most important points in this clinical vignette. So doing this actually allows you to compile all the information together in your head, because again, you're going to get very, very long vignettes. You're going to get very long scenarios. You want to be able to highlight the most important keywords so that you're able to look at the entire picture together without getting, otherwise it's just going to be word vomit and you're going to be very confused. So as you see in this patient, she's had UTIs in the past, and you can see that her presentation now, fever, dysuria, abdominal pain, and then suprapubic discomfort, points towards another UTI. Our diagnosis is actually confirmed by the urinalysis. So the fact that she has white blood cells and bacteria in her urine means, again, that she has a UTI. This is the CT shown of her abdomen. Would anybody like to go ahead and interpret this for us? So this is the kidney, as you can see. You can see the medullary papillae, and you can see the cortex. What do you think is happening here? So this is basically a horseshoe kidney. This is basically when both the kidneys are kind of combined this way into one long sort of mass. Okay. Which of the following structures has most likely limited the proper ascent of the anomalous organ seen in the CT? So which of these structures is going to cause is not going to allow the descent of the horseshoe kidney? Absolutely, you are right. A, the inferior mesenteric artery. Let's look at this picture right here. So as you can see, this is a horseshoe kidney. And this artery right here, the inferior mesenteric artery that is coming out from the abdominal aorta, this is not going to let this horseshoe kidney ascend upwards. Now, as you remember this patient's presentation, she has had UTIs since her teens, and she's now 47 years old. So she's had UTIs very, very frequently. The cause of UTIs is because, number one, because there's no proper renal pelvis, as you can see, because of this hole right here, there's no proper pelvis. So this area is most likely the uretero-pelvic junction is most likely going to be obstructed. This will cause compression, and so this can lead to UTIs. Another thing that's very common is right here, there's going to be a vesico-ureteral reflex. So every time the detrusor muscle contracts for micturition purposes, some of the urine is actually going to flow upwards. It's called retrograde flow. And so again, the bacteria is going to be introduced. It's going to go all the way up, and this can cause further UTIs. Moving on, a 56-year-old man presents to the ER with an inability to pass urine for the past 24 hours. When asked, he says he has hypertension and BPH, so benign prostatic hyperplasia, and that he was diagnosed 5 years ago. Physical examination reveals suprapubic tenderness. He says that he often forgets his medications and he's actually non-compliant. Urethral catheterization was performed to relieve his bladder obstruction. So this is imaging for his bladder. Which of the following is the most prone to injury during urethral catheterization? Now this right here, I put this on purpose because I want to make you guys aware of a certain kind of trick question that Alfaisal loves to give. Is basically when they don't match the numbers with the number of the MCQ. So 1 is not going to be 1, 2 is not going to be 2, and your brain is going to be tricked. So on this picture, whatever you think is the right answer, 1 is the bladder, 2 is the prostatic urethra, the membranous urethra, number 3. We have the bulbous urethra, and then the penile urethra, number 5. Again, the one you see in the picture does not correlate to the one in the MCQ, right? ExamSoft has ABCs, and so they're going to put ABCs on the picture, and those ABCs are not going to match with the ABCs of the MCQs. And your brain is going to get confused. You're already stressed out in the exam. You're not going to focus on these things. So I want to remind you guys to take a minute and look at the question properly. Let's look at the answers you guys are saying. 5, 5. Perfect. It is number 5. So if we go back to the question, you can see literally from here, the anatomy, you can see that this is the thinnest part of the entire urethra, the membranous urethra, number 3. And so this, when you're catheterizing, this is the most prone to getting injured. Number 5, okay. Moving on, a 28-year-old boy presents to the ER with acute onset of severe left flank pain radiating to the groin, gross hematuria, nausea, vomiting that is not associated with an acute abdomen. Below is the ultrasound of his left kidney. What do you think is the most likely diagnosis? Now, again, let's break down the question first. I've highlighted the most important points, and I would recommend you do the same in ExamSoft. So the patient has severe left flank pain that's radiating to the groin. This is a very classical presentation for nephrolithiasis or like renal stones. It is not associated with acute abdomen. That acute abdomen is basically abdominal pain. When you have a lot of abdominal pain, it's known as acute abdomen. So this patient doesn't necessarily have that. What do you think is the diagnosis? Renal colic. Absolutely, yes. But renal colic is what the patient's feeling, right? Renal colic is the symptom. What do you think is his diagnosis from looking at the ultrasound? Renal colic. Okay, so we have more renal colic. Again, renal colic is more so the kind of pain that the patient is feeling. So this would be a symptom. This would not be the diagnosis of the patient. So this is an ultrasound. And as you can see, this right here is the kidney. Okay. Renal stone. Thank you. So this right here is the kidney, okay? And as you see here, there's like two sort of opaque structures, and these are actually, yeah, they're stones. And how you would be confirming your diagnosis is because of this right here. Do you see this shadow that it's producing? There's two, because there's two stones. This shadow is actually called the acoustic shadow. And the way that this works is basically ultrasounds use sound waves, right? So you're gonna be sending in sound waves from the abdomen. When the sound waves come in contact with this stone, they're not going to be able to pass through the stone because the stone is just made of, calcium, oxalate, all of those materials that is not going to let sound pass through. Whereas everything else is basically soft tissue. This is not. So that's not going to let the sound waves pass through, and you're going to get this phenomenon that is known as acoustic shadow that is going to further confirm your diagnosis of renal stones. And casts a shadow. Absolutely, yes. Okay, moving on. A 24-year-old boy is getting evaluated for gross hematuria. Okay, let's talk about gross hematuria first of all. Are you guys aware of what that is? So hematuria, hemat, means that there's red blood cells present or blood, and then urea would mean urine. So hematuria is when there's blood in the urine, and gross just means that you can see it with your naked eyes. There's the other version of hematuria would be microscopic, which is only visible, you only see red blood cells in the microscope. So this patient has gross hematuria, which means he can see blood in his urine. Cystoscopy means, so there's cyst, which means bladder. Cystitis would mean infection of the bladder. Scope means camera. So cystoscopy is basically a camera that they insert into the bladder. So this is cystoscopy is performed. After the scope is inserted into the bladder, a triangular portion of the bladder wall is formed by the internal urethral orifice and two slit-like openings. Gross blood is seen oozing out from one of these slit-like openings. Which of the following is the most likely cause of the patient's presentation? Is it bladder rupture, colovesical fistula, renal papillary necrosis, urethral diverticulum, or urinary bladder cancer? Before you guys answer, I do want to say that this question, the options I would say at least, are a little bit advanced for your case, but I think I would say this is still pretty easy for your level because you can get to the diagnosis through a process of exclusion, and honestly, I would say it's relatively easy. So first of all, the triangular portion they're talking about is the tribone, right? It has the internal urethral orifice, and the two slit-like openings would be the ureteric openings. There's blood that's oozing out of the ureter. So which of the following can cause the patient's presentation? Bladder rupture is very unlikely because, again, the bladder seems to be intact during the cystoscopy, and the blood is coming out from the ureter. It's not necessarily coming from the bladder. Colovesical fistula. I am not 100% sure if you guys have taken fistulas yet, but a fistula is basically a connection between two different organs. So a colovesical fistula would be a connection, or this kind of basically a connection between the bladder and the colon. So a colovesical fistula could technically be bleeding, but what's important to note here is that because it's the colon, you would also see like fecal matter, and we don't see that here. A urethral diverticulum, again, we're not even in the urethra, we're in the bladder right now. So again, the urethra will most likely be normal. Urinary bladder cancer, again, the bladder seems to be okay. It's just the slit-like openings that are bleeding. The only choice left, again, we did the exclusion thing, would be C, renal papillary necrosis. Now let's talk about why that is. Oh, A makes sense. Hold on. Bladder rupture. No, okay. Let me show you why. It doesn't make sense. Okay. So we have to keep in mind that the blood is oozing from the ureter. Okay, we see blood coming out from this area, from the opening itself. Most likely, the blood that's coming from the ureter is coming from the upper urinary tract. So again, you don't need to know all of these conditions. This is more so just explanation purposes. Sorry. So if you have anything, any sort of lesion, any abnormality, any infection in the kidney itself, the blood is going to travel all the way into the ureter and come out from the ureteral opening, right? Whereas everything that's related to the bladder, related to the urethra, the bleeding is going to be more localized. If you see blood that's coming from the ureter itself, it cannot be a bladder cause. It will most likely be an upper urinary tract cause. Okay, somebody's saying I haven't seen this in the slides. Okay, I will show it to you after we're done. All right, once I'm done with my lecture. Okay, a 45-year-old man with a history of end-stage renal disease undergoes renal transplantation. The donor kidney and proximal ureter are transplanted in the right iliac fossa with implantation of the ureter into the patient's bladder. Now, again, this is a classical example of a clinical vignette that is very, very long. So again, highlighting would help a lot in this case. 6 days following the surgery, the donor kidney appears to be functioning well, but the patient develops fever and right lower quadrant abdominal pain. Imaging reveals that there's pelvic fluid collection, and when you do, so exploratory laparotomy is when you open up the abdomen to see what exactly is going on, because images are not helping you. So it turns out the patient has a urinary leakage, with ischemia and necrosis of the transplanted ureter immediately adjacent to the site of the implantation. The proximal portion of the ureter appears to be normal. Now, this is a humongous clinical vignette. Look at the question that they asked. The healthy segment of the patient's transplanted ureter is most likely receiving blood from which of the following arteries? So they did this insane clinical vignette, and when you first read it, you might even think that we've never taken anything like this. But when you read the question, they're really just asking about the blood supply for the ureter. So which of these arteries supplies blood to the proximal part of the ureter? Is it the common iliac, the internal iliac, the lumbar arteries, renal arteries, or the superior vesical artery? D, renal artery. Okay, let's see if the answer is correct. Why is that? So let's quickly review the blood supply for the ureter. So we have the abdominal aorta, which is giving the renal arteries right here. And the artery that goes to the kidney is going to make a quick branch for the proximal ureter right here. So the proximal ureter is supplied by the renal artery. The middle part of the ureter would be supplied by the gonadal artery branches, which can be the testicular in males or ovarian artery in females. And then the distal ureter would be supplied by either the common iliac itself, branch from the internal iliac, or a branch from the vesical artery. Okay, a 29-year-old woman presented to the ER with complaints of severe pain in her right back, which radiates from loin to groin and is associated with burning micturition for the last 3 hours. The physician found mild tenderness in the right iliac fossa, blah, blah, blah. All of this is normal. A sample of the urine looked dark and it was tested positive for blood. Her X-ray KUB is attached. After pain relief, she was referred to the urologists, and for further management. They basically did an X-ray for her, and they're asking us to identify the anatomical change in the X-ray. Let's look at the X-ray. So, can anybody tell me what abnormality do you see in this X-ray? Something that I think would be kind of a clue is that they're asking you for anatomical changes related to the urinary system. So what you can do is concentrate or like focus your search on where you think the urinary system would be present. So you can look at the kidneys, you can look at the ureters, you can look at the bladder. So where do you think you see something that might be abnormal? The kidney. No, not really. In the renal sinus, yes. Wait, renal sinus? No, no, no. Okay, listen. The air that you see here is not pathological. This is normal. I would advise you to focus your search lower down, maybe. Okay, so basically this right here. I know it's super tiny and it's really easy to miss, but there is a stone. It appears to be in the, hold on. Okay. It appears to be in the, what do you call that? The uretero-vesical junction. Yeah. So that's one of the constrictions that, of course, one of the three constrictions, and it's very, very common for stones to get stuck there. And this is where it appears to be, right here. For this, for the air, if you're not exactly sure why there is a lot of air here, first of all, there's obviously going to be bowels here. So again, the bowels are full of air. And secondly, the stomach would also be found somewhere in this region. And the stomach is known to have air in it. Again, that can cause um some of the air that you see in this X-ray. Mostly what they're going to ask you is going to be calcifications. So this right here, you're going to see this is very white in color because it's a stone. Mostly you're going to be seeing something white. So if you can be seeing a staghorn calculi, for instance, you can be seeing a stone in the pelvis right here, in the renal pelvis, or somewhere along the ureter. That is the most common question that they're going to ask you. Okay, so based on the attached X-ray, where do you think the patient is most likely having a calculus? Okay, so first of all, we need to know what is going on in this X-ray. You can see this is the ureter is very, very, very dilated. And then you can see this is the renal pelvis, the renal sinus area. And this also is this is the pelvis, the major calyces, they're very dilated. What do you think they're full of? In this case, it's contrast, right? So the urine is stained with contrast, and you can see the contrast all inside this area. This is a case of hydronephrosis. And hydronephrosis is when there's retrograde urine flow. And now there's an obstruction. There's some sort of an obstruction here at the bottom, which means that all the urine that the kidney is producing is getting accumulated here because it's not getting passed into the bladder. And so I would say this would most likely be present in the vesico-ureteral junction, or maybe somewhere along the ureter itself. Something else to note in this X-ray is that there is actually another calculi that you see on the other side. So this patient most likely had something like hypercalcemia or some or some sort of electrolyte imbalance, which led them to have, stones on both sides. All right, let's look at another CT. So, do you guys have any idea what we're looking at here? Okay. So on the right side, so it's very important to note that this is usually flipped, so this is the right side. So on the right side, the kidney appears to be normal on both sides, right? In both the pictures. But here you can see that you can see this is sort of the kidney, and there's some sort of a mass that's growing here, and it's infiltrating the kidney. So this is infiltrative renal cancer. Whereas this, again, you can see the kidney, it's better defined here, the kidney itself. You can see the medulla, you can see the cortex here. And this right here is the mass. This is well defined, and this is just infiltrative, so it's like the whole kidney architecture is ruined, whereas here the kidney is a bit more maintained. So this is what cancer would look like on this kind of an imaging modality. Before I start this question, I want to ask you guys, I'm not sure if you've taken urinary incontinence. Can somebody unmute themselves or text on the chat? I I feel like you have, but at the same time, I didn't see it on any of the PowerPoints that I had. Mm-mm-mm. Guys, anybody? Okay, we touched on it in physio. Okay, perfect. So I will try to explain this to you guys. I hope it's not too complicated. It's even if it is, I will explain it to you fully. So inshallah, if you do get anything that's even remotely similar, you will be able to answer the questions. So, a 48-year-old woman comes to the office due to 6-month history of passage of urine when she's sneezing or coughing. Recently, she experienced some urine leakage even with her normal day activities, and this has led to some embarrassing social situations. She has no numbness, weakness, or fecal incontinence. She has a known case of hypertension and diabetes mellitus. She has had 4 uncomplicated vaginal deliveries. Okay, somebody is saying, "Ee, smarty pants." Okay, which of the following is the most likely cause of the patient's condition? Bladder outlet obstruction, detrusor muscle inactivity, overactivity, diabetic autonomic neuropathy, or urethral sphincter dysfunction. Let's go over these a little bit briefly. So bladder outlet obstruction, she doesn't really have any of the symptoms of obstruction. If you look at the question, she's had 4 uncomplicated vaginal deliveries. So every time you deliver vaginally, just naturally, you're going to have weakening of the pelvic floor muscles because of the passage of the head of the baby. Again, all the muscles are getting stretched out, so they're going to get weaker in general. And the fact that she's had 4 kids means that her pelvic floor muscles are quite weak. Every time that she sneezes or coughs, her intra-abdominal pressure increases. And now her urethra, the pressure of her urethra is no longer enough to contain the urine. So it's just going to dilate a little bit and she's going to pass some urine. Detrusor muscle inactivity, overactivity, so why this would not be a neuropathy is because they've mentioned in the question no numbness, weakness, or fecal incontinence. Usually when you have either muscle weakness or some sort of a tingling sensation, numbness, this usually indicates that there's some sort of a neurological deficit, right? So there's something that's wrong with the nerves in the area. However, she doesn't have any of these. She's negative for these, so it cannot be a neuropathy. So urethral sphincter dysfunction makes the most sense in this case. All right, so just to go over this briefly, what she has is stress incontinence, which is when you have leakage with coughing, sneezing, or lifting heavy objects. Usually the urethral sphincter tone is decreased, again, because the sphincter, in essence, is a little bit weaker or damaged because of the vaginal deliveries that she's had. Next, we have urge incontinence, which is because of the detrusor overactivity, sudden overwhelming urge to urinate. So this is basically when you have the smallest amount of urine in your bladder, but your bladder, because it's overactive, would want to is sending signals to your brain that, oh my God, I'm full, I need to go and pass the urine out. So you're just gonna get even with the smallest amounts of urine, you're gonna get the urge to pee. And it's usually very overwhelming and it's sudden. Lastly, overflow incontinence. This is because of bladder outlet obstruction or because of detrusor inactivity. What happens is that there's incomplete emptying of the bladder itself. So because the detrusor is not able to contract properly, not all the urine will pass out, or because there's an obstruction at the bladder outlet, again, not all the urine will be able to pass out. This is actually BPH. And so the bladder is never going to get empty every time you go to the bathroom. So then you're going to get persistent dribbling, incomplete emptying. You're always going to feel the need to pee. And yeah, that is the differentials for urinary incontinence. All right, so we're not completely done yet. I would like to go over this other PDF. Again, I should not take more than 10 minutes, I think, inshallah. I know you guys are probably in a rush. I know you want to go self-studying. Let's just quickly go over this. So there's this website. Hold on. There's this website called the University of Michigan. I'm not sure if you guys have been exposed to this, if if one of the doctors might have told you about this. But basically, they have a lot of anatomy questions on their website. It's obviously it's for their students. However, sometimes our professors bring questions from this website as well. So if you ever have the time, I would highly recommend that you go over these. They have a lot of different resources. So they have practice questions, PDFs, just radiological images that you can go over if you have the time. So I'm just going to be using one of their PDFs. Okay, let's start. I've seen that they bring gross images in your exam, so I just wanted to go over these just briefly. Again, we're gonna try to finish this in 10 minutes, inshallah. All right, let's start. Okay, I want you guys to be really, really interactive so we can finish this really fast. What do you guys think this organ is pointing towards? This blue line is pointing towards. Again, I'm open to any answers, anything at all. It can be wrong. It doesn't matter. I just would love to hear something from you guys. The peritoneum. Let's look at the answer. So it is the renal fascia. I know it looks like the peritoneum, but yeah, the renal fascia itself. Let's look at this second picture as well. It's pointing towards this structure in specific. I think saying peritoneum was a really good guess because again, it is connective tissue you see here. But since the kidney is right next to it, this is renal fascia instead, yeah. Okay, so this is pointing towards the fat in this area. So this is just going to be the kidney fat and the perirenal fat, all of this. Okay, this organ right here, I'm pretty sure this is honestly really easy. So this is the kidney. This structure that you see coming out of the kidney going downwards is going to be the ureter. Excellent. And whatever you see here, the yellowish stuff at the back is going to be so the perirenal fat, the fat surrounding the kidney. Exactly. Okay, moving on. So what do you guys think this is? It's pointing towards this triangular structure right here. Okay, let's go over this quickly. So the renal pyramid, the medulla, exactly. This is the medulla, but since this is a triangle in specific, we would call it the renal pyramid. Let's go over this. The outside area is going to be the cortex. These sort of columns in between each of the different pyramids are going to be the renal columns. Again, this is invagination sort of the cortex in the medulla. So this is still the cortex. And lastly, this is the apex of the triangle of the pyramid, and this is called the renal papilla. All right, what do you guys think this is? The pelvis. Yes, exactly. This area is the pelvis right here, but what do you think this structure in particular is? The renal artery. Let's look. Exactly, perfect. So this is the renal artery. Um, oh yeah. So this is not going to be the renal vein because the diameter seems like it is a little bit bigger than the vein would be. This most likely is the vein right here. Okay. These structures right here form, what do you guys think? Oh, it's not here. Sorry. Let's talk about this first. What do you guys think this is? Okay. So this is the renal sinus. This right here, this area would be the renal sinus. It's mentioning to this area at the back. So renal sinus makes sense. Let's look at that. This is pointing towards the fat. Do you see the yellow colored fat? And this is how we know this is the perirenal fat right there. Okay, now this, I'm not sure who said renal pelvis, but yeah, so now that they're talking about the entire hilum. Oh, this is the hilum. Okay, yeah, sorry. The pelvis would be this. That's my bad. The two major calyces would form the renal pelvis, and then this would form the ureter. This entire area of the kidney in general is called the hilum. This is the medial border of the kidney, and the renal fibrous capsule. You can almost see, it's almost as if you can see the fibrous capsule, and then that is the cortex. The fibrous capsule is extending all the way around, and then that is the cortex, and then we have the medullary pyramids. Okay, this is the renal pelvis, the ureter, and then the two major calyces. The smaller ones right here would be the minor calyces. Again, we once again have um the renal papilla and then the renal pyramid. Okay, for this one, I need you guys to be really, really attentive because they bring pictures that look exactly like this, and there's a very high chance that something similar to this will actually come in your exam. So what do you guys think this is right here? It's pointing towards this thing. Actually, let's start with this one. What do you guys think this is? Left renal vein, left renal vein. Perfect. How do we know this is the left renal vein? How do we even know that this is the vein, for example? This, as you can see, first of all, the color, I feel like kind of gives it away. This is a more reddish color. This is a more bluish color. You know, even if you weren't able to tell from the color, you can see that this right here, the abdominal aorta, is very, you can almost see that it's a bit thicker than this structure right here. It appears to be, like, it appears as if it's holding its own shape. It looks cylindrical, kind of. Whereas this vein, you can see that it's very flat. It appears to be thin. It appears to be like deflated almost. So basically the arteries are gonna have, obviously aorta is gonna have its own muscular structure. It's gonna be able to hold its shape even without the blood in it. Whereas this is just gonna be more deflated, more thin. And again, the color kind of gives it away as well. The left renal vein. And then what do you think is on the other side? The right renal vein. Perfect. What do you think this is? Okay, so somebody's saying that the inferior vena cava would be on the right side and the abdominal aorta would be on the left. That is also, honestly, that is also a good way to remember. But just based off of appearances, I think, you know, if you wanted to double check, because right and left can be kind of confusing in the exam. Okay, so this is basically, this is the right renal artery. So from the abdominal aorta, I feel like you can kind of see it going to the back. It is a little bit difficult to make this one out, but yeah, right here. Let's now let's look at this structure right here. So something that is sort of going over top of the left renal vein, and it's coming out of the abdominal aorta. What do you think this structure is? The superior mesenteric artery. Perfect. And oops, I never gave you a chance to talk about that. But yeah, this is the left gonadal vein. This is not very important to know. I think as long as you know the superior mesenteric artery, the veins and the arteries, you're good to go, honestly. Okay, another one of these diagrams. Let's talk about what this structure is. It's pointing towards this structure. So this is the abdominal aorta, and it's coming out of the abdominal aorta and it's giving branches to the kidney. What do you think this is? The left renal artery. Perfect. And then this right here, it feels like this structure is coming out from the kidney, it seems like. And it's very thin and it's traveling all the way down. What do you think that is? The ureter. Perfect. Okay. Now this sort of seems like anatomically, how would you know where you are? This seems like it is the bladder. It seems like it's the bladder. So this is the leg. This is the patient's femoral region. This is the leg. It seems like they've cut it open. You can see a kind of like a triangle structure here. There's two openings here, and then there's another one right there. What do you think these are? The ureteric openings, perfect. And then this leaves us to the last opening, which is most likely the urethral orifice. Okay, so right off the bat, you can see that this structure right here is really sticking out, right? This structure is very, very, again, very, very, I feel like you're gonna be able to tell exactly what it is the moment you look at it. Can anybody tell me what this is? The uterus. Perfect. So this right here is the uterus. So by extension, if this is the uterus, what do you think this would be? The vagina, right? This is the vaginal canal. What is posterior to the vaginal canal? What do you think this is? Posterior to the vaginal canal. It's almost as if there's an opening here, and then this right there. The rectum, absolutely. And then this is the rectum, and then this you see right here is the structure. Also, the shape of the structure is very, very characteristic. What do you think that is? The bladder, absolutely. And then if that is the bladder, it's resting on top of the pubic symphysis. And lastly, this would be the urethra. So now this is a female cross-section, whereas this would be a male cross-section. Now this right here is the bladder again. We're dividing the urethra into three parts. First of all, we have the prostatic. This is the prostate, by the way. This right here would be the prostate. So prostatic urethra. Then we have the membranous urethra, and this is the part, again, do you see the way that it's kinked here? And it's also thin. So this is the part that's most prone to injury during catheterization. And lastly, we have this entire part, which is called the spongy urethra. But this area is usually divided, the spongy urethra is usually divided into two, into the penile and the bulbous urethra. Okay, that's pretty much it. If you would like me to, again, I've already given you guys the resource that I've used. I can just give you a PDF if you would like to go over it again. Again, this is a very great resource for anatomy questions specifically. So if you would like to use it in the future, please feel free to. Okay, here is the PDF that I used if you would like to go over it again before the exam. And that's pretty much it. I would love to know if you guys have any feedback. Again, be it positive, negative, it can be constructive, criticism, anything good that you liked. I would love to know. Please feel free to scan the QR code and fill the form out. And that's it. Thank you so much. This is again my email and my phone number if you would like to reach out for any purpose at all. I wish you guys the best of luck in your exams. And yeah. I hope everyone does really, really great. Thank you so much for attending, and I hope that this PowerPoint was of benefit to you.